He has completed his fellowship in implantology from IBOI and trainer of implant dentistry and periodontal plastic surgery, and he has conducting workshops for the same. He is a postgraduate guide since 15 years and also examiner at various universities. He is a renowned speaker at various platforms of periodontology and implantology across the country. He has guided over 115 short researches and 36 original research for MDS postgraduate and published more than 35 articles. Welcome, sir.
Thank you, ma'am. To acknowledge the presence of such a wonderful person as a chairperson. It's not an easy thing to succeed after two wonderful talks. Okay, my job is going to be just a gap between your talks and the one to come next. It's not from the land of Kandara, ma'am. I come from still down south, it's Kerala. I represent the Department of Clinical Periodontology and Oral Implantology at Royal Dental College. That's at Palakkad in Kerala. Okay. As we move ahead, this textbook with its 14 editions had been a fantastic part of the entire journey of modern periodontology that started in 1953, that's around more than 70 years ago. And now as it moved on with all the 13 editions, and when we come to the final in 2023, the 14th edition, that change is very much evident here. The name of the textbook itself has changed from clinical periodontology, and it has added another science name onto it, that is implantology. But we, most of us sitting over there, the senior people out here, along with me, we have all done our post-graduation during the era of 8th edition of this textbook. This era where extraction of teeth were considered a failure of periodontics or even periodontology. There were serious attempts to retain every grade mobile teeth with a flap surgery during that time. But we know we were spectators at the big game implantology happening on the other side of dentistry, which was taken care by prosthodontists and oral surgeons. Periodontists were never made a part of the playing team in implantology at those times, not your generation. Especially in the smooth, easy winning game, we were never a part of it. But we were definitely called in at times of its crisis, breakdown, and failures. That was the time when a periodontist had to be a part of this great team. As such, the crisis were something like this, wherein some specialists have placed it, and we were never part of it. We were never taught or trained how to do implant. But in situations like this, where the extreme end happens, where it just pops out from where somebody has placed an implant, then that was the time when periodontists were called in. And periodontists were never included in the planning or placing of the implants during that time. But in cases of the so-called peri-implantitis, it was all referred to us. This was not just the case of implantology. Periodontics was such always. It was never a part of the planning or the training program of orthodontics, never endodontics, never a part of prosthodontics, or even an oral surgery. But anything goes wrong with any of those specialties, when they overdo any of those kind of their procedures, then things were referred to us. So we were like running a garage without knowing the driving. So eventually what happened was this textbook with that name of clinical periodontology slowly started changing its form into something else, and all the textbook had one addition of something in between in the cover page at least, showing some part other than the real hardcore periodontology, that was implantology. And when it came to the final 14th edition, the name itself changed and it became clinical periodontology and oral implantology. That is the kind of change that I have noticed during this process of my career in implantology. Yeah. Now, what you understand an implant as a restorative procedure, everything seen in a patient's mouth and appreciated by all, that is what is being seen in a patient's mouth as an implant, was a part of prosthodontics or a prosthesis with its all science and its principles. What is not seen, what holds the processes inside, what is not seen by the patient by himself or appreciated by any, was exactly or really the part of the implant. And that was purely governed by the periodontal principles and the laws. Something wrong with the, yeah. So when an implant is placed inside alveolar bone, the periodontal area is reborn as peri-implant area. The alveolar bone regeneration takes another term called osseointegration. The gingival sulcus is reborn as peri-implant sulcus. The reflow of gingival clavicular fluid again happens in another name, that is peri-implant circular fluid. The new band of biologic with certain changes in its width happens, and it's formed around the implant again as the same thing. There happens a cessation of attachment loss. Then interdental bone is reborn here, which was just a ridge before. The crestal bone resorption slowly ceases down. There will be a transmission of force happening inside the alveolar bone, which was same for the periodontal ligament earlier. Yeah. A peri-implant bone failing to hold implant is simply following its memory of periodontitis. So for implants, signs of its existence is just same periodontal principles. Yeah. Having said this, I'm coming into the topic for today, that's the role of periodontist in oral implantology. Something went wrong with this. We're talking about the role of periodontist in implantology. So in hardcore periodontists, the so-called the periodontal specialists, cling to the hardcore periodontal part of it, or the periodontics part of the science, dedicated to everything possible to retain a natural teeth. Resective surgeries were the choices over restorative techniques like implants. So such periodontal surgeries often gifted patients with a worse looking post-op or pre-op conditions. When you consider a pre-operative picture and the post-operative picture of many of the periodontal procedures, the patient often appreciate the pre-op to be better than post-operative conditions. Most often these cases even failed over a period of time and left the area with hardly any bone to place, or a reasonable sized implant was not possible in those areas after undergoing all those periodontal surgeries. Patients who could afford to undergo all periodontal procedures to retain it till that moment, with all the kind of restorative procedures to that moment, we prescribed whatever things for them to do to retain those teeth, and finally they were left with no bone to place a right-sized implants. Retaining a non-mobile teeth with reasonably less attachment loss is fine, but attempting to retain a mobile teeth with a heroic attempt of periodontal procedures needs definitely an introspection. It's not necessary that a patient should continue smile the ugly way or chew with a mobile teeth because their teeth have another few more years left in that natural form. It's not necessary. So a dedicated periodontist should not be a reason for a faithful patient's ugly smile for sure. It's retaining periodontally compromised teeth should be valued over a better implant restoration for sure. So it's something like extraction of teeth is no more done to get rid of a tooth problem. Extraction of teeth in implant era is to give a better option for a patient to smile and chew than in a compromised condition. Like this, a periodontist should be a reason for a faithful patient's better smile, where you change the smile of this patient to this, not the other way around. Periodontology has still wider applications in implantology than dealing with its ailing or failing stages, coming into a picture of saving it. It has a role in applying periodontal plastic surgical procedures, the regenerative procedures, all kind of guided tissue regenerative procedures, and more in implantology. Something like a need for a complete closure of such a case of a socket mouth after an immediate implant placement. Then the procedures of periodontal plastic surgeries comes to picture, where you can try a placement of a graft graft of a hard tissue nature and then a soft tissue nature, something like a connective tissue graft being procured from a palate and placed in that position and try to close it. That becomes a procedure of periodontology incorporated into implantology. When there is a thick soft tissue graft need in an area of extraction for a socket preservation, to make it a more vulnerable area for periodontal implant placement in future, it's trying with a palatal graft which is procured from the connective tissue side of the palate, is something which is pediculated to that area, which is the same palatal graft which was taught to us in periodontology, can be tried over here. And when it comes to a condition like this, where there is an exposure of the thread of implants and you are called in to do something over there, the same periodontal plastic surgical procedures can be utilized here to cover it up. The same sector can be utilized here. And in cases of GBR, it's like a rebirth of the old GTR, where a collagen membrane and a bone graft can be effectively utilized to create the extra bone required during the healing process. A GTR membrane can be utilized here. Guided tissue procedure can be utilized for the betterment of the implant placement. Where one procedure which we are very much familiarized in periodontology, that is the art of hemisection, can be utilized again in this procedure, where you have a furcation involved tooth which needs a hemisection. That area becomes a potential place for an immediate implant placement also, something like this. You have done the hemisection, remove the root from there, then you can directly go in for an immediate implant placement in that socket site, and definitely substitute that area with one implant. That also is possible, which is definitely hijacking of the periodontal procedure into implantology as well. Same, something similar to this. There is a furcation involvement on a tooth, and the buccal root, the distal buccal root is being encroaching into the implant site of the nearby area. Therein, this procedure has to be done by furcation involvement treatment of radisection, thereby getting some space over there to place an implant. So the periodontology procedure comes into one of the role of placing an implant in that particular site, which was otherwise not possible for a right-sized implant to be loaded there. This periodontists who believe in retaining natural teeth till its last breath, whatsoever bad condition it is, then for them, contribute to implantology. But for periodontists who understand implantology as an extended science of periodontology, supporting implant the way it supported the teeth previously, for them, this role in implantology is unsubstitutable. Good periodontist in search of a right indication to extract a periodontally hopeless natural tooth and replace it with a perfect implant, then you will never get to do implant by yourself. All you can do is watch and criticize every other specialty person or someone with half the surgical skill of yours doing it. That's all. If you are an excellent periodontal surgeon with an ability to shut patients' queries, asking and saying all after your periodontal surgery, if you want the tooth to be longer or you want your teeth any longer, such kind of a questions, retain your natural teeth as long as possible. Whatever is given by God is to be retained for as long as possible through maintenance phase, through its mobile, though it is mobile and receded with spacing and bleeding, still let you have this tooth for a longer time. You have lived enough for this subject. It's time to retire. You may be now a hindrance to the progress of the subject. It's time that you stop it and give away your chance to the person who is more well versed with perio as well as implants. Apart from the mechanical principles of this restorative techniques and material science, the biological aspect of implantology is completely periodontology oriented. Without periodontology and implantology, dentistry is nothing but a branch of just bioengineering. So eventually what happened was, from the 8th edition to the 14th edition, The clinical periodontology became totally clinical periodontology. We added implantology, became the bread and butter of nowadays today's generation periodontists. Even in implantology conferences like this, where the tagline has become a completely the largest implantology conference in the country, and when ISP is extending its scholarship to the implantology people or the people who are doing research on implantology, where in periodontist, doing an implant is definitely a choice, but for implants, as far as implants are concerned, the only choice of existence is to follow the periodontal principles. So thank you once again, or rather thank you the whole Indian Society of Periodontology for giving us a chance to present over here. Thank you for your patient listening.